Okay, so I always keep the small structural case in the end because I believe that we are entering into the era where structural cases are going to increase further, and that gives you a you know overview that how structural cases are being done. So this is another structural case which I've done last month or so. It was a complex case, but this case also tells that how a good planning can uh, lead to a very successful outcome with these cases. So this is a TAVR with a complex anatomy. So look at this. This is a patient demographics, and so patient is obviously having a critical aortic stenosis, but then there is a history of coronary heart disease in the past, hypertensive, rheumatoid arthritis, complete heart block, and then EF is 40 to 45%, and now the patient is severely symptomatic. Echo shows clearly a severe aortic stenosis while the PA pressures are still okay. So this is the CT. Now look at this valve. It is a very bad calcified bicuspid valve. We can see on the CT, it's a type 1 bicuspid valve, 1A. There is a raphe here, which is calcified and badly calcified rather. The coronary heights were okay. Sinusoval valvas were okay. This is how we read the CT of a for a TAVR patient. We need to look at the annular diameters, the coronary heights, the sinusoval valvas, everything. So now calcium is one thing which is very important. Bicuspid is another thing which is very important. And third is very important is what is the angulation of the aorta, whether it is more than 60 degree or less than 60 degree. And one more thing which I want all of you to note, this is a good dilatation of ascending aorta. See the ascending aorta here is 47.6, 4.7 that means. So it is towards the higher side. This is how the patient presented, very symptomatic, critical AS, previous CAD, not a surgical case. So that's where we took him up for a TAVR. Now look at this. This is again another important thing. What is the horizontality of the aorta? Angulation. So angulation is 66 degree. So anything beyond 65 becomes a complex one in calcified bicuspid valves much more. Now, one thing also I like to add here, which is of interest to everybody, if your ascending aorta is dilated, this 66 degree of angulation will behave like a 80 degree. Because once you start pushing to cross the valve, once you have taken, I'll show you, once you take the valve at the aortic annulus and try to push across the aortic valve, that pushability will take the hardware into the ascending aorta more towards a greater curvature, and it will become almost a 80-degree angulation. So this is what is the problem, and especially if you are doing a bicuspid calcified with the angulation like this, with the ascending aorta dilatation, then plan it prior that you take the help of a snare. So we were anticipating based on our earlier experience, having done more than 300 hours, we know that these cases we will face a big difficulty in pushing the valve across the aortic annulus. And sometimes it doesn't go. Then you have to take out the valve, the whole hardware, and then go again. Then try to have a Linderquist wire, uh, have another access from the radial, pass another wire through that. So it becomes very messy. So based on that experience, we took a snare. So look at the third video. There is a snare initially, and this snare should be at the beginning. While you cross with implantation diagnostic and cross with the wire, the thermo wire, the aortic valve, everything should go through this snare. So I think you all can visualize everything is going through this snare. We cross the aortic valve with the wire, and then have a safari wire in place in the LV. Again, everything is through the snare, and then having a balloon through this snare with which we are dilating the aortic valve. So this is very important. And now look at this. So ballooning is done. Everything is going through that snare. And this is the second video now where we are taking a Myval. So Myval is getting stuck. There was a calcium at this point, all at the subclavian descending junction. There is a calcium, lot of calcium, and valve was getting stuck here also. But somewhere, manipulating the valve, flexing the valve more, we could manage. So now the valve is in position. Look at the third video. That's what I was trying to say. Now, once we start pushing the valve to get so that it enters into the calcified aortic valve, and partially it is in the LVOT and partially it is in the aorta, there is a lot of difficulty. While we push, the whole hardware sits on the greater curvature, and that 66-degree angle looks like a 80-90-degree angle. This is the most difficult point in these anatomies. Now, so valve is not entering because it is more towards the non-coronary cusp. It is not towards the aortic valve opening. So in normal situations, you keep trying, because if you push more, there is always a risk of a tear. So now look, next video will show you how handy this snare would be. So look at this. So now once we are pushing, one, there is a pushing motion, and second, there is a lifting motion with the other associate of mine is lifting through that radial. The snare is being lifted up, is catching hold of that valve, and like we lift up our baby, we lift up the valve, and I'm pushing. So another associate of mine is lifting through the snare, the whole hardware where the valve is, and then it enters. So it makes it much easier. And once it enters, you take back the snare, it remains in the ascending aorta, and then you dilate this valve, and then everything sets in place. So valve dilatation, and look at the final video. It's 30.5 Myval deployed, very calcified bicuspid anatomy, settled very nicely. So snare is a beautiful adjunct, beautiful help and beautiful support in such cases where it's a bicuspid calcified valve and angulation is more, and especially if the ascending aorta dilatation is there. So always preempt to pass everything through the snare. You can have a snare through the radial artery, and all the hardware is coming from the femoral, but right from the beginning. You cannot plan it later. It has to be with the first step. So then it settles. So preempting, planning, and uh, just discussing prior to the case is much better rather than conquering or confronting the complications later on. So this was my case. Hope it was productive. And with this, I thank everybody for being here on this Sunday. And I think this was a beautiful session.